Anyway, good. Okay, Emma, thanks very much for coming, and over to you.
Lovely, thank you very much. So hi everybody. This pillar is going to be very annoying, so I will try and decide where I'm going to stand in relation to it. So I should say this work that I'm going to talk about today is joint work. Because I'm a philosopher rather than a scientist, I'm not very good at including the "this is the team" slide that you get in most talks, so I'll just quickly tell you about the team. It's joint work between myself in philosophy at Reading, a couple of other philosophers, Nat Hansen and James Stazziger, who's now joined the King's College Philosophy Department. Some psychologists, in particular a psychologist called Tim Salomons, who's just moved to Canada. And also some people down at the Royal Berkshire Hospital, so we've been really lucky to work with some people. So Deepak Ravindran, who's been most closely involved out of the team in the work today, is director of the pain clinic at the Royal Berkshire Hospital, and we also work with some other people down there. And we've also had input from local pain support networks, in particular chronic pain support networks, so we should definitely acknowledge the role that the patients have played in developing our ideas here as well. Okay, so I'm going to talk about understanding thought and talk about chronic pain. And to give you the plan for today's talk, I'm going to start off by asking a good philosophical question. What is pain? Okay, should be really easy to answer because I'm assuming all of us have experienced pain at one time or another and knew it when it came and caught us. So it ought to be easy to answer, but it turns out to be very difficult to answer. I'll have a little look at what the clinicians might tell us pain is, and I'll have a little look at what the philosophers might say pain is. But I'm going to do that quite quickly, and I'm going to suggest that actually we might be better off turning our attention away from that, what philosophers call metaphysical question about the nature of pain itself, and asking what I think might be a slightly more tractable question about how ordinary people talk and think about pain. So what do they say about pain? How do they conceptualise pain? And I'm going to suggest that those questions might be better ones to be asking, and I'll try and give you some answers about them. And then I'm going to suggest that the way that we answer these two questions leads or promotes a particular kind of approach to the concept of pain that I'm going to call a polyeidic view. Polyeidic means kind of many ideas. And I'm going to suggest that the way we talk and think about pain suggests that the notion of pain we're using is complex in certain kinds of ways. But I'm going to go again through that relatively quickly, so I think if there are any philosophers in the room, Alexander and others, you're probably going to find what I have to say here kind of unsatisfactory. I mean, you might all find everything I say unsatisfactory, but I'm kind of expecting philosophers to find that bit a bit unsatisfactory because it might go a bit quickly. But that's because I'm assuming that most people here come from a more clinical background. So what I really want to get on to talk about, and what I'll close with, are what we take to be the potential clinical repercussions of the view that we want to defend. I guess just out of interest, show of hands, who comes from a more philosophical background? Who's doing philosophy? Okay. And who is from a more clinical background? Okay. So it's kind of almost even. So, okay, excellent. Well, that's really good. So let's start off then by thinking about what pain is. And if we're on the clinical side, what might we say pain is? Well, one thing we might say is that pain is nociceptive activity in the pain receptors, the kind of activity that's triggered by some kind of noxious stimuli. So for people who are familiar with the literature here, if you take some seminal kinds of accounts of pain, maybe something like Melzack and Wall's gate theory of pain, what you'll find is that they talk about pain as occurring very early in the system, right? So there are pain receptors outside the brain. These receive, sometimes they talk about it as nociceptive activity, but sometimes they also talk about it as pain. And it's a little bit unclear whether that's just a way of speaking or whether it's a genuine substantive claim about the point at which they think pain emerges in the system. Oh, sorry. Anyway. Alternatively, we might think that pain is some kind of brain state, or could just be completely exhausted by talking about the brain state. You know, I did philosophy, I was an undergraduate doing philosophy a long time ago, but at that stage it used to be very common for people to say, when they were talking about type identity theories or token identity theories between brain states and mind state, that a good example of this was pain, because pain was C fibers firing. And I think even in those days, philosophers didn't really think that was the right answer, but it was a nice kind of catchy phrase. Things have got a lot more sophisticated. I think one of the best accounts along these lines is the work by Wager and his colleagues, where they've used machine learning techniques to try and identify a particular neural signature for pain states. If I was giving a different paper, I would talk more about this, and in particular some work by my colleague Tim Salomons, who's tried to show that even though this work is it's very sophisticated and very interesting, still not clear that they're really homing in on a pain state, a state that's unique to pain, as opposed to a state that's common across a whole range of different salient phenomena to us. And finally, we might say that pain is a mental state. Maybe it's a way of feeling, an affective or emotional state that we enter. And indeed, if you take the most famous clinically relevant definition of pain, it comes from the International Association for the Study of Pain in 2011. They offered a really nice little snappy definition of what pain is. They said that pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. And you can see that the emphasis here is very much on the idea that pain is a sensory and emotional experience, a mental state. And the IASP offered this nice, very short definition, but they backed it up with a much longer note that tells you more information. I won't give you the note in full, but just to say, oh, my slides don't quite fit, how annoying. They say, the note goes on, that activity induced in the nociceptor and nociceptive pathways by a noxious stimulus is not pain, which is always a psychological state, even though we may well appreciate that pain most often, can't see it, but I think it goes on, most often is related to a particular bodily state. It's a damaged state. So here you can see that they're directly kind of contradicting our initial suggestion that nociceptive activity would be sufficient for pain. What they're saying is that that might be a cause of pain, it might be an early state, but the pain happens downstream of that. Right? It's always a psychological state, it's always a state of the person. So what about philosophers then? What do philosophers have to say about the nature of pain, what it essentially is? So pain's been much studied by philosophers. It's been something that they've been interested in thinking about, and there are a whole range of different theories of what pain is that we could go and look at. One of the most common is to treat pain as a kind of representational mental state, so something along with other states that represent something about the world, tell us something about the way the world is, and they say that what a pain state represents is a state of damage to a part of the body. So when you're in pain, you're having a state that represents your body as being damaged. Alternatively, you find philosophers who focus on the affective or the phenomenological aspects of pain. They say that pain is the way that pain feels, and you find that in particular in Kripke, stressing that phenomenological quality. Just recently in philosophy, there's been something of a mini explosion in studies of pain, so there are a whole range of new theories of pain that have come out. Perhaps one of the most interesting ones comes from Colin Klein in a series of papers and in his 2015 book, where he suggested that to be in pain is to have an imperative instruction, like a mental state that tells you to do something. And he thinks what it's telling you to do is to protect a part of the body. So having a pain in my foot is telling me to favour that foot, to protect that part of the body. So if we were doing a purely philosophical talk, we could spend some time outlining these theories properly, and we could decide what we think is good and bad about them. You know, as in all philosophy, each of these theories has something going for them, but they all face kind of significant problems with various different kinds of pain. And I think that a promising line of investigation here, instead of continuing to ask this, quite difficult, nebulous, metaphysical question about what is pain, might be to ask what looks like a potentially more tractable question, which is how do ordinary people think and talk about pain? And we might think that this is a relevant question, because it seems to be that it's the way we think about pain that's responsible for a lot of our pain experience, right? It's because we conceptualise pain in a certain kind of way that we'll count the experience we're having now as an experience of pain or not as an experience of pain. And indeed, as I'll try and suggest later on, other ways in which we think about pain seem to have significant effects on our pain experience as well. So asking this question about how it is that we conceptualise of pain might, I'm going to try and suggest to you, be potentially as clinically relevant or perhaps more clinically relevant than asking this fundamental question about what pain is in the first place. And I've suggested that it might also be more tractable. You know, I think the most appealing of these philosophical accounts is, you know, something along the lines of Kripke. To be in pain is to have a particular kind of feeling, a particular kind of phenomenological state. That's certainly been picked up in psychology, but it's hard to know where you go with that, right? If you say pain is a certain way of feeling, it looks like a bit of an explanatory cul-de-sac, right? It's hard to know how you go further with that. And I think that's well demonstrated by a psychologist called Field, who went for this kind of phenomenological approach and introduced this special terminology for the special kind of feeling that pain has. And introduced this label, algosity. That did not catch on. You don't find that being discussed very much, and I think that's a recognition that, you know, once you say there's this fundamental kind of brute feeling that just is pain, it's hard to know how far that takes you down the explanatory road. So I'm going to turn then and ask these questions about how we talk about pain and how we think about pain. So let's turn now to the language of pain. What do we say about pain? Well, some authors, particularly on the humanities side, have suggested that pain necessarily outstrips language. They think that pain just can't be captured in words, can't be communicated to one another through the use of language. And perhaps the most famous example of this is Virginia Woolf in her 1930 essay, where she writes, "Let a sufferer try to describe a pain in his head to a doctor, and language at once runs dry." There. And this is a kind of approach that's found a lot of resonance amongst many writers. So Elaine Scarry in her 1985 book says similar kinds of things. And perhaps most famously, Joanna Burke, both in her 2014 book and various other places, talks about her pain as beyond words. So this precise phraseology actually comes from a nice New York Times article by Burke in 2014. And she's talking about having had an operation, being in hospital, coming around in significant pain, and she has a visitor, and she's talking to him, and she says, you know, "I'm in agony here, my pain is beyond words." To which her kind of perceptive visitor says, "Well, maybe, but you've been talking about it for the last 20 minutes. And that seems like a genuine recognition, right? You may think it's beyond words, but it doesn't seem to stop us trying to talk about it. And what Burke's visitor goes on to say is, well, maybe it's not the case that you can't talk about pain, maybe it's the case that your audience just doesn't listen, refuses to listen. And I'm going to come back to that at the end and try and suggest a slight twist on that position. So I think although there is something to the idea that pain outstrips our language, and again that's something that I'll try and make sense of when I present my positive view a little bit, it's still natural for us to talk about pain to one another. And if you do any kind of corpus study of everyday dialogue, you'll find that quite a lot of it concerns talk about pain. So how do pain terms crop up in language, and what have philosophers had to say about the way we should analyse their meaning? Well, one common move has been to treat pain terms as what philosophers call simple referring terms. So this is the idea that there are some bits in our language whose sole function is to label things in the world, just like name tags that we kind of hang off things. And this kind of view goes along with a certain kind of reification about pain. It's treating pains as objects, things that you can attach labels to, things that you can count. I have one pain here and another pain there. Seem like quantifiable, countable things that you can pick out using these kinds of referring expressions. And the idea is what they refer to is some specific kind of internal mental sensation, token of a specific mental sensation. But alternative accounts have been proposed. Some people treat pain terms as more descriptive expressions, so telling you something about the way that properties are related in the world. And in particular, philosophers have suggested that we might adopt what's called an adverbial analysis here. So this is the idea that pain terms don't refer to something in the world, they're not referring to a specific object, they're telling us about a kind of experience. So so you might say, you know, I've got a pain in my chest, but you might analyse that as I'm feeling my chest hurtingly, or something along those lines. There's no object picked out there other than the chest, and what you're doing is you're ascribing a property to it, a certain kind of way of feeling. And Ty and others have liked that because it avoids this kind of reification, it avoids treating pains as objects. And finally, you find some accounts where pain terms are treated as what we might call kind of expressive expressions. They're not thought of as carrying what philosophers call semantic content. They don't really have substantive meaning. They're more akin to just grunting or crying or shouting. They're just kind of expressions of an immediate effective response to a stimuli. Okay, so those are some of the ways that pain terms have been analysed by philosophers, and if I was giving a different kind of paper, I'd give you them in more detail, and I'd try and suggest what each of them gets right and what each of them gets wrong. But I'm not going to do that because I want to get on to my positive view and I want to get on to the clinical repercussions, so I'm just going to suggest to you, and we can come back to it in discussion if you want, that each of these accounts seems to get something right about the way that we use pain terms, but none of them seem fully adequate or fully sufficient. So, you know, you just have to look at the way that pain terms occur in a language to see that you get a variability across these different kinds of accounts. So we say things in English like there's a pain in my chest. Pain here is behaving in this first kind of way. It's talking about a countable thing, an object that I can pick out. But we also say my chest hurts. And that looks a lot more like this kind of descriptive type of analysis. What we've got here is a process term, right? It's not a kind of count noun in the way that it is in the first term. And indeed, if you look at some languages, you know, in English there tend to be more of these kinds of locutions where we've got something referential by the look of things going on. But in other languages, so if you take something like Polish, much more common to talk about pain in this kind of process way. And so what I'm just going to suggest to you then is that this variability that we see in linguistic role might suggest a degree of flexibility in the way that people are conceptualising pain. The fact that we find this variability in language might be good evidence for a flexibility in thought as well. So let's turn to thought now. What can we say about how we think about pain? So this is another point that philosophers have had something to say about, and they've been particularly interested in the fact that ordinary people display a certain kind of tension in the way that they think and also talk about pain. So people will think of pain as both a purely experiential state. I think this is kind of the natural way that people think about pain. If you ask them just off the bat how are they thinking about pain, they will tell you that it's a feeling or an experiential state, or it's, you know, something in the mind. And as such, it's potentially divorced from states of the non-brain body. But on the other hand, they also very commonly talk about pains as states that are located in and are properties of body parts. So we say, I've got a pain in my knee. That's where the pain is. In my knee or in my foot or in a particular part of the body. But that is a weird thing, right? Because we don't do it for most other mental states. We say, I've got a pain in my knee. We don't say, I've got the belief that 2 + 2 in my knee. Or I've got a desire for a new bike in my finger. Paradigm mental states don't get to have bodily locations in that way. But pains belong to this weird category where they look like they're mental states, but they're mental states that have this particularly intimate relationship to the body and which can be held to be located at given bodily parts. So this recognition then has led some philosophers to posit what they call the paradox of pain. I should say this should be the paradox of the concept of pain. Okay, they're not. It's a question about how we think about pain, not necessarily pain itself. So the paradox of pain emerges from the fact that sometimes people think of pain and awareness as separable, where pain is treated as an objective feature of a body part, and I'll call this the bodily conception, and I'll give you a little example of it in a moment. It's most associated with this bunch of what are known as experimental philosophers. They do, well, we'll see in a second who they are. And sometimes people think of pain as requiring awareness, as constituting a mental state, and that gives us this kind of mind-centric approach. And I'll say a little bit more about both of them in a second, but the fact that we have this kind of tension in the way that we think about pain leads Hill to say that ordinary people have a paradoxical notion of pain. Inbuilt to our ordinary concept of pain is the paradox between it being a mental state and it being a bodily state. And experimental results show that this paradox of pain reflects a robust distinction in ordinary ways of thinking. So, just to give you some examples here, this is from Justin Sitzmer, a paper he wrote on unfelt pains, and what he did was present a range of these vignettes to ordinary people, get them to respond to them, and make some conclusions, draw some conclusions about how ordinary people think about pain. So here's one of Sitzmer's examples. Patients who have suffered bodily damage can get wrapped up in other things in such a way that they later report that they were not aware of any pain during the period they were concentrating on something else. In such a situation, do you think that the injured person still had the pain and was just not feeling it at that moment, or that there was no pain during that period? How about a quick show of hands? Who thinks that the injured person still had pain and was just not feeling it at that moment? Okay, so, and who thinks that there was no pain during that period? Okay, I think that's more people. Okay, that's hooray! Well done, everybody.
What's the right answer?
In fact, either answer is fine. That's a nice thing about these experiments. So Sitzmer found that participants were willing to allow that the subject can be in pain and yet not feeling it. He found slight flip side of what we've got in the room. More people, he found, wanted to say that the injured person still had pain and just wasn't feeling it at that time. And that leads him to say that if folk are willing to allow that there are or can be unfelt pains, pains that exist without awareness, then we should conclude that people think of pain as a non-subjective state. Just in the way that buses and tables and my foot can exist without me being aware of them, so we should think of pains as things in the world like those, that they can exist as properties of body parts that I'm sometimes aware of and sometimes not aware of. Now, just to kind of give the game away, I think this is okay as far as it goes. Okay, what Sitzmer and his colleagues use these experiments to try and argue is that the ordinary common sense notion of pain should be viewed as entirely bodily. He thinks that this is the only notion of pain that people have, because he runs a range of these experiments and this is what he finds. What I'm going to try and suggest to you is that it's quite right that sometimes people do think of pains in this way. Sometimes people really do adopt this kind of very body-centric view where pains are things, are properties of body parts that they might be aware of or they might not be, and that can exist kind of independent of awareness. But that doesn't exhaust the ordinary notion of pain, because sometimes people think of pains in different kinds of ways. So in response to Sitzmer and others' experiments, we've run some experiments of our own in the experimental philosophy. So here's one of our thought experiments. So Maya is an ice skater who takes a bad fall on the ice and injures her wrist. At the time, she says it doesn't hurt, even though the damage to her hand is evident to all. It swells and it bruises. Later on, looking back on the incident, Maya remarks, "Oh, it was the darndest thing. Although I couldn't use my hand properly, it never actually hurt. Not when the accident happened, not when they were treating it at the hospital, and not when it was bandaged up. Although I could see the damage, it was never actually painful." And then we have a Likert scale here, and we've phrased two questions on a scale of 1 to 7. Maya was aware of pain from this injury, and Maya had pain from this injury. So the first is a kind of test for comprehension, right? What do we answer to this question? Is she aware of the pain? No, she just told you that she's not aware of pain, so we ruled out anybody who gave a different answer there. The interesting one here is question 2. Maya had pain from this injury. So who thinks Maya had pain from this injury? Hands up. Hands up if you don't think Maya had pain. Hooray! You can all take part in our experiments. That's the answer we're looking for. We do think that in this case, and what we found in this case, people go our way or go the mind-centric way. So this is a problem case for Sitzmer and others, because here it seems that the bodily injury isn't being treated as sufficient for pain. It's really the awareness that matters for having pain. So we want to suggest that there is this genuine divide between the way that people think about pain. Sometimes they think about them in this body-centric way, sometimes they think about them in this mind-centric way, and that actually the way that you frame the question that you're asking can direct people to having one kind of thought or another. So, you know, we're quite upfront about this. It's the way that we frame this question that gets you to, or tends to get people to answer in a certain kind of way. But what that shows, we think, is that there is a degree of flexibility in our ordinary thinking about pains. We can be directed to think about pains in different kinds of ways. So the positive view that we've tried to construct to accommodate this kind of flexibility then is something that we call the polyidic view. And we treat this, so we want to say that these two ways of thinking, this mind-centric and body-centric dimension, is indicative of a kind of broader flexibility about the way that we think and talk about pain. So we want to say that the ordinary notion of pain is polyidic, it's a many ideas concept, whereby the concept of pain is viewed as an amalgam of several distinct dimensions along which pains can be ranked. So I've only talked about one so far, the mind-body, but we take it that that's a kind of dimension. People can think of pains in a more body-centric way or a more mind-centric kind of way. These ideas or dimensions can come into conflict with one another. We think that's what we're seeing when you find, when you talk about the paradox of pain, it's the idea that these dimensions might be able to conflict. We think that subjects hold latent positions on these rankings. So we want to suggest that people have, we don't like the label unconscious bias, but people come to pain experiences with a certain kind of mindset about pain, certain latent judgments about what pain is and how it relates to bodily states. The next point, those rankings are subject to framing effects, and the point we really want to claim is that these positions have direct behavioural effects. So the way that you're thinking about pain will influence the way that you behave in relationship to certain kinds of experiences and the kinds of treatments that you are able to benefit from. So we want to say that pain, this is the concept pain, because I've put it in capitals, that's what philosophers do. As soon as I've got it in capitals, it's fine, it's a concept. The concept of pain, the ordinary, everyday concept that ordinary people use when they're thinking about pain, shouldn't be treated as a primitive, non-decomposable concept identified by either just its affective properties or some other kind of set of properties. Instead, pain should be viewed as a complex amalgam of these different kinds of dimensions. So again, I've only given you the one dimension, so even if you believe what I had to say about the mind-body distinction, you might say, well, hang on, you've shown me one distinction, but you've just given me a theory that posits lots of dimensions. That massively goes beyond what you've just shown, and that's quite right. So I will absolutely take that, and it might end up we're aware that that's the only dimension we can really vindicate. And I should say this is work in progress, so we'll just see where we get to. But at least initially, we think that there are other dimensions that are worth exploring, and some of our experimental work supports these ideas. So we think that people take different stances on the idea of whether pain is necessarily useful. So sometimes people have a kind of latent view that says that pain is just useful. It's always useful because it's telling me something about my body. And in fact, I can't remember whether I was going to say this now or later, but I'll say it now because it struck me. So as part of this work, we've done quite a lot of interviews with chronic pain patients. It's chronic pain that we're really interested in rather than acute pain. And lots of interesting things have come out of those interviews, but one that I found particularly interesting was that we asked a lot of patients about their relationship to their medication, about how they felt about the medication they were treating, that they were being treated with. And I was expecting patients to feel a bit conflicted about their medication. But I was expecting them to feel conflicted because I thought they will think, you know, the medication is good because it helps with the pain, but I don't like the side effects. You know, a lot of the side effects for pain, chronic pain, have some really debilitating side effects. And I thought that would be where people found problems. But actually, quite a lot of the patients said, oh, I don't like my medication, I don't like taking my medication, and I don't like it because it just masks the pain. And that struck me as a really odd thing to be saying, right? Because if you think that pain is a feeling, if you think that what matters to pain is the way that it makes me feel, then masking the pain should be just fine. You know, if you stop having that feeling, that should be sufficient for them being, treating the pain. But what these patients were saying is, it gets rid of the pain, but it's just masking it, it's still there, it's, I know it's still, it'll be there when I stop taking medication. And my suggestion is that one explanation of why they view that is because they're thinking of their pain as necessarily useful. They're thinking that it shouldn't be masked. This pain has to be telling me about something that requires treating, requires fixing. And if you just mask it, then I'm not learning all that important information about my body that I should be. So we think that people take different stances on this idea of pain being useful or not useful. We think people take different stances on the idea of the public versus the private dimensions of pain. So this goes back to that idea that pain might outstrip language, because we might think of pain as a kind of essentially private mental state, something other people can't have access to, and we find that in kind of common statements like, well, no one else can really know my pain. I can talk to my clinician about my pain, but he'll never really understand it because he hasn't had it. And that contrasts with views of pain where there's taken to be an important social element to the pain, where the pain is exacerbated or arises in part due to our relations to other people. So pain crucially involves on this kind of account a kind of signalling to and a response from others. This is something that, as I said, you find in some of the humanities work, but kind of really interestingly, these last two papers are a response to a call to update the IASP definition of pain and a call for suggestions about ways in which it could be helpfully updated. And at least two authors here have suggested that the way it needs to be updated is to include this more public aspect, this more social aspect of pain. Finally, the question of motivation. Does the subject always think that pain has to engender action or try to engender action, or do they accept that pain can be non-motivational? It's interesting, philosophers tend to focus on this motivational thing. If you think about the imperative account that I offered a moment ago, it's kind of premised on the idea that pain is always motivational. But actually, if you think about chronic pain, it can often be a bar to action. It often restricts or debilitates the patient in terms of action. So again, we think people adopt different positions with relationship to these different kinds of distinction. So I'm not going to go into those. It's a kind of sketch of the polyeidic view, and I'm not going to go into them because I want to get on to, what time should I be finishing, by the way? Sorry. Just keep going.
We've got until 2, but no.
I won't be until 2, don't worry. No, that's fine.
Yeah, including some discussion.
Yeah. No, that's fine. I don't know.
Yeah. No, it's good. It's good.
It's good. Okay.
How can you stop that?
So I'm just going to put these out here as possible dimensions. As I said, this is kind of work in progress. We've got some really great postdocs who are helping us out in thinking about these, and we're hoping to do more work on them, but we'll see. But I'm just going to leave them because what I want to get to really, and what I'll close with, are why we might be interested in this kind of account. Why might the polyeidic view be of possible interest, and a possible interest to an audience like this that has people who do clinical kind of stuff in it. And we think it might be interesting because we think that it might have genuine clinical repercussions. So as I said, we're particularly interested in the treatment of chronic pain. And it's interesting to note that when you look at the history of the discussions around pain in philosophy, it's almost always acute pain that people focus on. So if you think about philosophical accounts of pain, their model for what pain is putting your hand on a hot plate and taking it off because it really hurts. And that's that kind of acute warning role of pain, telling you about ongoing or imminent bodily damage. But chronic pain is clearly a massive part of the story about pain here. So chronic pain is pain. Sometimes it's defined in terms of the length of term that the pain has been going on for. Sometimes it's defined just in terms of pain that outlasts a period of healing. So it's pain that continues over a long period of time. It might be kind of episodic, and it resists biomechanical kinds of treatments, right? And we know that chronic pain, the prevalence of chronic pain, or at least the reporting of chronic pain, is massively increasing. So chronic pain is a huge cost to health services like the NHS now. And the common treatments for chronic pain either seem just to have not very good outcomes, so the kind of surgical interventions for lower back pain or shoulder pain, chronic pain in those areas, don't seem to have particularly good patient outcomes. Or indeed, sometimes they have worse and just not very good ones. They have genuinely harmful outcomes. You know, we're all familiar with a massive increase in opioid misuse, particularly in the States, but also in this country. And that has a lot of its roots in the treatment of chronic pain. And I'm sure everybody here knows that the treatments that are given for chronic pain, the kinds of pharmaceutical treatments that are given, are often incredibly powerful opioid drugs. If you take those daily for just a week, that can be enough to create a physical dependence. And so when these things are assigned for chronic pain treatments, they're often given over a longer period of time, and it leads to serious issues with addiction. So the current treatments for chronic pain seem problematic, either unhelpful or genuinely damaging. So it seems that there's a genuine need for some different kinds of thinking around here. And we think that the polyidic view might be helpful because it seems to be relevant in at least the following kinds of areas. So we think it might help in patient and clinician communication about chronic pain. We think that it might be helpful in profiling chronic pain patients prior to treatment. I should have said this is joint work with all of the collaborators, but in particular with Deepak, the guy at the pain clinic at the Royal Berkshire, and this is probably the thing that he's most interested in. And I'll say a little bit more about it in a second. We think that it might help patients in general to accept a diagnosis of a psychosomatic element to their condition. And we think that it might, this is the most speculative, it might hold out the hopes for improving cognitive or expectation or placebo-based treatments for chronic pain. So I'll just close by saying a bit more about each of these. So communication of pain. With one of my other hats on, my primary role is as a philosopher of language. I've been particularly interested in questions of communication, how we get messages across to one another. And pain is an area, chronic pain is an area where this seems particularly problematic. So the chronic pain patients that we talk to have often reported to us that they have trouble communicating their pain to their clinicians. Say either the clinicians don't seem to understand them, they don't seem to listen to them, or that their experiences are just not being well captured by the kinds of assessment techniques that clinicians are using. And on the other hand, there's pretty much a wealth of research showing that clinicians often find patients with intractable pain both problematic and frustrating. Okay. These are patients that are very difficult to treat. You know, they've often been through the hospital for a very long time. They've had a range of different, often invasive or unpleasant treatments. It's no wonder that they're frustrated and angry, and they often take that out on the clinicians that they end up being seen by. So we want to suggest that both clinicians and patients might be able to benefit from some kinds of preliminary work which would clarify how the other is thinking about pain and to promote the kind of common ground that's necessary for successful communication. There's a lot of evidence that if you feel your clinician is empathetic, if you feel that they're supporting you, you will benefit more from the treatments that they're giving you. And we suggest that doing some work to think about how individuals are thinking about pain can help to promote that kind of relationship. So crudely, it's a hypothesis, but we think it's plausible that clinicians tend to come to pain with a more sort of body-centric view. And that's where their training lies, in thinking about the way that the body gives rise to certain kinds of conditions. And that's when they come to a chronic pain patient, they continue to have that more body-centric notion of pain. But with the chronic pain patients, it's a particularly mind-centric view of pain that's driving them. It's the way that the pain feels to them and the kind of impact that feeling has on their day-to-day function that really matters for them. And we think that leads to a kind of failure of communication, not enough common ground to promote successful communication. So we think that there might be some preliminary work we could do there. And we also think that when we're asking questions about the ways in which pain gets assessed, if we were to adopt this kind of more articulated notion of the concept of pain, where we recognise that there's a range of different dimensions, we could get some assessment techniques that are more fine-grained, more suited to those kinds of articulation and thinking. So with chronic pain, the McGill Pain Questionnaire, I'm sure you've all seen, is good. You know, it's much better than the simple kind of 1 to 10, tell me where your pain ranks against other pains that you've had, or the worst pain you can imagine, or pains you had last week. You know, there's a lot of problems with those scalar kinds of questions, and the McGill Pain Questionnaire does a lot to address that, because it draws out many of these different dimensions. It has a lot of different sensory categories, so it'll ask you whether your pain is throbbing, or stabbing, or a range of different vocabulary terms that seem to label different kinds of pain. But we want to suggest that that kind of questionnaire could be improved by further work to draw apart these different dimensions of pain. So not just the sensory dimensions, but asking people, you know, the extent to which they think of pains as things that are internal and private and unshareable, the extent to which they think of pains as things that are related directly to bodily injury or tissue damage. And that could give us a better kind of model of the patients that we're treating. And this leads me on to the second point here, the idea that we might be able to profile patients that arrive in pain clinics prior to delivery of treatment. So what happens now is that patients who exhaust standard surgical or pharmacological treatments for pain without substantial improvement are likely to end up being referred to pain clinics. And when they get into the pain clinic, if they're lucky, they will be given access to a range of services, including physiotherapy and expectation-based programs like CBT or ACT, and other services like mindfulness training or meditation. So these kinds of slightly non-standard treatments, non-biomechanical treatments for pain. And what will happen is that access to these is just, what you get when you get to the pain clinic. There's no kind of filtering of patients across these kinds of treatments. And that means that, you don't really know whether a patient is going to be able to benefit from any of these treatments before you send them. And pain clinics are very stretched, like all other aspects of the NHS. These treatments are expensive, and it would be better if we could direct the resources at those who are genuinely going to benefit from them, and then could undertake some work with those that we don't think are going to be able to benefit to put them in a better position to be able to benefit from those treatments. And we would suggest that referment for treatment is going to be improved if clinicians were able to assess what we might call patients' pain priors. So the beliefs that people have about pain are going to influence how amenable they are to these different kinds of treatment. So again, when we talk to the chronic pain patients, lots of them had been on mindfulness training, lots of them had been on courses teaching them how to live with their pain, about the idea that their pain might have a psychosomatic dimension. Some of them said, yeah, it's brilliant. It's the only thing that brought any light to my experience, and things have been revolutionised by these kinds of treatments. Others said, totally hopeless. It didn't help me at all. This was just, why were telling me that I should spend some time meditating? How should that help my lower back pain when, that's about something that's gone wrong in my lumbar spine? And we think that if we could get at the way that patients are thinking about pain, the degree to which they're thinking of pain as something which is mind-centric versus body-centric, we would be able to identify better which patients might be able to benefit from these kinds of expectation-based treatments. And really, if you've got chronic pain, it's physiotherapy and CBT or ACT or something like that that's going to help you. It's not having another surgery. It's not necessarily going on with pharmaceutical treatments. Right, next one. So in general, patients with chronic pain are often going to be told that there might be a psychosomatic dimension to their experience. They're often going to be told that the pain that you're experiencing may not result from some underlying biomechanical cause. It may result from something in the mind, to at least a degree. And chronic pain patients are often extremely resistant to that. They're extremely resistant to thinking of their symptoms as in any way emerging from the cognitive side of the divide. And they continue to seek a biomedical explanation long beyond the point at which further clinical or surgical investigation has proven worthwhile. And this is another kind of interesting point from talking to Deepak. You know, he says he'll spend a lot of time with patients, very sensitively introducing them to the idea that maybe there's a mental component, a cognitive component to their experience of pain, and facilitating the idea that maybe something like mindfulness, maybe something like CBT could be helpful to them. They will begin to become more amenable to this. They'll then go back to see maybe their GP or someone at a hospital who will say, oh, you know, I just thought maybe there's this new kind of surgical procedure that you could undergo. I haven't recommended this one to you yet, but there's another operation we could do on your shoulder and maybe that would help. And in a moment, that completely reverses all the work that Deepak had done. It pushes them straight back to thinking there's an underlying biomechanical cause, and if I have enough surgery, that's going to sort it out. And we hypothesize that the chronic pain patients are resistant to this kind of diagnosis for a number of reasons, but at least because maybe they continue to believe that their experience of pain is useful, in that it is genuinely indicating some somatic disturbance that needs medical intervention. So they're just convinced that the pain is telling them about something that can be fixed by some sort of biomechanical intervention. Or maybe they think that their experience of pain can only be validated by finding an underlying biomechanical cause. I don't know, did anybody see there was a program on BBC Two, I think it was, just last month about the placebo experiment? Did you saw that? Yeah, I mean, it's a really good program. So they ran a placebo experiment with a number of chronic pain patients, and they saw who benefited and who didn't. I'll say a little bit more about placebo in a moment. But I thought one of the really sad things about that program was that they then got together all those people who had an effect, who had a genuine placebo effect. And this had been really significant in some cases. You know, in some cases it led to people who had been wheelchair bound, getting up and moving, you know, genuine, significant effects. And they were then told that what they'd been taking was a placebo, not a live drug. And the response from most of them was, oh my God, I feel so ashamed. Oh, you know, I feel like a fraud. I thought my pain was real, but now you're telling me it's not real. You know, and that, you know, that's horrifying. That you can think that because you're being told that your pain might have a cause that lies on the cognitive side, that entails that your pain isn't real. And I think what we really need to work on here, in an area where I genuinely think philosophy might have something useful to do here, is to help patients understand how, because something has a cognitive cause, doesn't invalidate your experience of pain. It doesn't entail that your pain isn't real. It's just as real as it always was. It's just that the cause may not be the one that you really thought that it was. So we think that the polyeidic view here might be helpful because leading people to think more about what's involved in a pain experience, about how it relates to the body, how it relates to the mind, might help people to create a room in their own minds for thinking that they have real pain, but that it's pain that has a psychosomatic element to it. So as I say, modulating the dimensions of pain thinking may help patients, and indeed the public at large, right? It's clear that another reason, I haven't mentioned here, that patients feel uncomfortable with the diagnosis of psychosomatic conditions is because of the general social stigma that's associated with any sort of condition of that kind. So we think they would help the patients, but it might also help the wider public to come to appreciate that being a psychosomatic condition doesn't invalidate an experience of chronic pain. Finally, this is the penultimate slide, we kind of would like to think that maybe this way of thinking about things might open the door to some improvements in the expectation or cognitive-based treatment of chronic pain. So top-down psychological treatments are amazing things, right? It's amazing what kinds of effects your mind can have on your body. And in terms of pain treatment, placebo and other sorts of expectation-based effects can operate on different aspects of a pain experience. So sometimes they genuinely alter the underlying biological response to a nociceptive stimulus. So they can modulate the autonomic and neuroendocrine responses, and they can affect peripheral cortisol levels. So a placebo treatment given in the right way, given in a way that promotes the association between the treatment and the reduction in the pain experience, will have genuine, will have biological effects on the patient. And they can also alter things on the cognitive side. They can alter how a subject thinks of, ranks, or reports their pain. And we want to suggest that the polyidic approach might help in designing more targeted psychological interventions, targeting what I earlier called the unconscious biases that might exacerbate a patient's experience of pain. So just to give you an example of how we think this might go then. Think about chronic pain and control. So there's a wealth of experiments, a lot of them undertaken by my colleague Tim Salomons on the psychology side, showing that our sense of control modulates our experience of pain. I get you into a lab and I tell you that I'm going to give you some kind of noxious stimuli, and I tell you you can choose either whether you have it or you don't have it. So I might say, I'll give you a quid if I can put this heat thermode on your wrist, but you don't have to do it. You're not required to do it. That will be reported, the pain that you'll experience from that will be reported as much lower than a subject who doesn't get a choice. It's just a given. Even if you keep the stimulus exactly the same, pain that you have control over is reported as regularly less intense than pain that you don't have control over. And we think that so a sense of control then matters because it affects how intense you will treat a pain as being. We think that someone with a particularly body-centric view of pain is likely to view their pain as something that they just lack any control over. If you're thinking of pain as a property of a body part, it's unlikely that you'll think that that's something you could have any kind of psychological control over. So compare the damage done to your hand by putting it on a hot stove. You don't have any control about how damaged your hand gets by putting it on that stove. That's just about purely kind of physical, external causes. And if that's the way you think of pain, as it's similar to that, you're likely to experience a similar lack of control. So we think that by shifting a subject's beliefs about pain along this dimension, it might be possible to increase their sense of control, thus reducing the intensity of the pain experience and thus the disabling constraints on function that are associated with chronic pain. Okay, so just to conclude then. I've suggested to you that there's robust evidence that our concept of pain is articulated at least in terms of a mind-centric, body-centric dimension. We think of pain at least under these two dimensions, and I've tried to suggest that there's also preliminary evidence that subjects rank their pains along a number of other dimensions as well. And I've suggested that to accommodate that, we should adopt some kind of polyidic account of our ordinary thought and talk about pain. We should accept the idea that the concept of pain is an amalgam of these distinct dimensions, not a kind of atomic concept in the way that philosophers sometimes talk about it. And finally, I've suggested that the polyidic approach might hold out the promise of improvements in patient-clinician communication about chronic pain and in the assessment of chronic pain patients pre-treatment, and that a highly articulated polyidic model might also provide a good framework for explaining and potentially improving top-down treatments. Right? It's an amazing feature of chronic pain that it's susceptible to this kind of top-down modulation, and we think that really regardless of the polyidic view, there is a big call for better explanation of how those top-down processes are working, which ones are really relevant, and how we design better top-down processes, better top-down treatments for specific patients, right? Not generalising across the whole body, but thinking about individuals and the way that they might be able to express control over their pain. And I'm just going to finish, not entirely related, but with my favourite cartoon about pain. So we think that the situation that chronic pain patients are in is often like this patient here. They've got an experience, they're meeting their clinician, and they're being asked to make a choice on something that they feel doesn't reflect their experience at all, and where mapping it onto this kind of existing assessment is not going to be useful. So I'll stop there. Thanks.
Thanks very much, Emma. What we'll do is now sort of stand.
It's already
Okay, folks, let's ask questions, engage in discussion. Who wants to go first? Did you have a hand? Yes.
Yes,
Yeah,
I'm not sure whether I'll be able to explain myself very well.
No.
But so you mentioned that if we accept this polyadic approach, it will help assessment techniques and kind of broadening out the dimensions in which we talk to patients. But if we kind of accept the poverty of language with reference to pain and the fact that on like a general public level, people are fairly like positioned in the way that they see pain, does that mean that we first have to like train patients to think in the polyadic way in order for these assessment tools to then work, because otherwise it's like you're talking to them in a different language almost?
Right. So I think that's a good question. You put it perfectly. Don't worry about it. So I think we want to claim that patients do already think in these polyadic ways. I mean, we do think that people just, so the experimental stuff we talked about with the mind-body, that's experiments that we run with ordinary, what philosophers tend to call the folk in a slightly patronising kind of way, just ordinary people who take these, we expose them to these vignettes, and we find that they will flip their views between these different kinds of polar different positions depending on the way in which you frame the things. So the hypothesis really is that people do just naturally have this kind of multi-dimensionality. We do think that you may get kind of ossified, your concept may kind of ossify into a particular set of latent positions, so I think that's particularly why chronic pain patients may prove so intractable very often, is because they've got a very fixed mindset around their pain and about the properties that it has and the effects that it's going to have on their life. So that's a bit of an aside. So your question was, if you think there's this poverty of language issue, do we have to train people to express their polyadic thoughts beforehand? And I guess I want to say no, because I think I'm not going to fully buy into the poverty of language point. So, thank you, that reminds me of something I was going to say when I was talking that I forgot about. So I really like that Joanna Borg story about being in hospital and saying, oh, my pain is beyond words, I can't express it, and someone pointing out, you've been going on about it for the last 20 minutes, clearly you think you're doing something here when you're not just making a noise, right? You don't just think you're, you genuinely think you're getting some content across. And I think that response is kind of right. We do think we can say something about our pain, and it will depend on which aspects of our pain we're kind of focusing on, the degree to which we think we can't express it. If I'm thinking of my pain absolutely as a purely kind of ineffable feeling that is unique to me and my experience, then obviously I'm going to think that outstrips my language. That's by definition what it is to be ineffable. But it's not necessary that we think of our pain in that way. We might think of it as a mental state, but one that can be common across a range of people. We might think your pain just is like my pain, even if it's a sensory state. And we might think about pain as having a closer connection to the body, and that being something that we can discuss. And as I mentioned, these updates to the IASP definitions, the idea that pain really does have, the way that we think about pain really does have these important kind of social dimensions, I think really is really right. Pain isn't always thought of as this entirely internal thing. It has these important social dimensions, and when you stress those, people find it much more easy to communicate about their pain. So I don't think we need to train people, but I do think we might need to make sure people are on the same page. So I think what I would like to say about that Borg example is, it's not that pain is entirely beyond words, and it's not that people just won't listen when chronic pain patients are talking. The worry is that people are coming at those conversations with these kinds of unconscious biases or these kinds of latent beliefs about pain that make it really difficult to hear what the other person is actually saying. And if we could get a bit more common ground there, then actually things would become easier. So that's a very long-winded answer. Or was it an answer? Right?
No, thank you. Is there any possibility that, I've not read the article so I don't know, but with the Borg example, the fact that so the visitor said, oh, you've been talking about this for a long time, is that not an indication that the language is poor? Because if you can say something quite succinctly and put your thoughts across, then you won't be talking for a long time, but like I tend to do, I can't explain myself very well, so I just keep going. Do you know?
I think it can pull you in either way though, can't it? I mean, you might think, look, if it's simple, I ought to be able to say it in a few words, but on the other hand, you think that bits of language carry genuine semantic content, and the more of those that I put in, the more kind of detailed thing I'm going to be saying. You know? And I think that relates to this, I haven't got the slide up, but you know, some philosophers have suggested that you could offer this kind of expressivist account of language around pain, where it is just, you know, I might be screaming or I might be shouting I'm in pain, but they're both doing the same thing. It's just this immediate response to the sensation. But I think that is wrong, and it's shown to be wrong by these kinds of examples, that quite often when you have a pain, you'll talk about it a lot, and you'll use a lot of words, and you think what you're doing is expressing more content, and you might still feel that there's a bit of a gap between the thing I'm really trying to talk about and the things that I'm saying. But I think, you know, you have a sense that you're getting closer, you're managing to convey some content.
I thought it was a very interesting question. But if you think that for some chronic pain sufferers, or perhaps even many, there's sort of the ossification of where they are on these dimensions is a hindrance, then that sort of raises the question, again, about some kind of work you might need to, as it were, to loosen de-ossify as being helpful.
I mean, that's right, and so we do agree with that. We like that kind of idea, that there could be some kind of, you know, educational materials that you could present to pain patients, some thought experiments to get them to work through, some help with the way that they're thinking about pain, that will make, I mean, we were thinking particularly about making treatments more accessible for them, but it would also make communication more accessible for them. I mean, I think we do like this idea that, you know, we could kind of modulate the way that a chronic pain patient is thinking about their pain in a way that puts them in a much better position to benefit from top-down treatments.
Yeah.
And if you can do that, then that's also going to take it help with the kind of community stuff as well.
Good. Thomas, you had a question?
Yes, I guess I have a sort of philosophical question. So, did I understand right that the underlying idea is a little bit like revisionist? That in the sense that what you're saying is a concept of pain influences the experience of pain, or even the pain itself. So when we revise the concept, or at least when people become aware of it, we are able to sort of intervene on the experience, or even the pain itself. Or is it just that we sort of teach people how to analyze their concept better?
I mean, I don't know.
It doesn't really affect the pain.
So why I'm feeling slightly like I don't want to absolutely agree here is, you know, I don't really want to answer this question about what pain is and the ways in which you can affect it. You know, in some ways I think that's a slightly irrelevant question in some ways, because, you know, if you want to treat someone's pain experience, it is massively affected by the way that they're conceptualizing their pain. And we could have some kind of error theory about, you know, pain is really like this, but the way we think about pain is like this, and those two just don't match up at all. You know, for philosophers, that is a feasible line that we could take. But I think in that situation, it really is the concept of pain that's carrying most of the work here. So I'm kind of, I don't know whether when you do work to modulate someone's concept of pain, that can affect pain itself. Because maybe pain itself is something like, you know, maybe it is just a brain state, but even then you could change. Yeah. I don't know. I don't know what I want to say about those metaphysical questions. I think I just want to make a slightly less committal claim that our experience of pain depends in large part on the way that we conceptualize pain, and we can change our experience of pain by modulating our concepts. And whether that is tantamount to altering the pain itself, I think I could just leave as an open question, it would seem to me, but maybe that seems problematic.
Yeah, I don't know. So can I ask a further question?
Yeah,
So,
sure. Yeah.
so apparently you think that there's this sort of looping effect between the concept
Yeah.
and at least the experience.
Yeah, that is.
So should we revise our concept just generally, not just in these clinical settings? Or?
So I think, should we, well, I mean, I don't know that we need to revise it in general. You know, the claim is that we just, as ordinary people, come with this ordinary conception of pain that has all these different dimensions. And I should say, I've stated the theory in its strongest form here, which is an account of the concept of pain. I don't know ultimately whether we're going to be able to defend that. May turn out that actually we don't want to make that very strong philosophical claim. Maybe we want to claim, you know, so my other work is really in semantics and pragmatics, and at least some of us in the group sometimes think that really we should be treating this as a kind of pragmatic-y framing effect rather than part of what constitutes the concept of pain itself. We might well end up with that kind of position. So I think the important thing is recognising that there are these dimensions to pain and that they have these kinds of roles. Exactly where we choose to situate those dimensions then might be something that we have to investigate further. What was the question again? I've now lost track.
No, it's all good stuff.
So that's all good stuff, roughly in line. But we definitely do want to claim that there is this kind of looping effect. And I think control is one of the really clear cases there. You know, it seems to be a very experimentally robust finding that we will report a stimulus as less intense if we think we have control over it, a pain stimulus, if we think we've got control over it, as opposed to not thinking we've got control over it.
Can I just, Nick, under your explanation, to ask something on that. So I wasn't quite, I went on to say something about the control point.
Mm-hmm.
And it seemed to be that you wanted to ally this with having a more body-centric view, or that you felt less in control. If you had a more body-centric view, you would feel less in control.
That's the claim.
Right. I wasn't. I guess I wasn't quite sure. I felt I wanted to go along with you on that. I mean, I suppose one. I suppose in the case of chronic pain, I can see what that's the case. But in acute pain, you might think, well, actually, that's a nice case where I do have control. I just take my hand off the plate. Whereas, on the other hand, is it the case that I think I have full control over my mental states?
Yeah.
Such that. Anyway, I just that wasn't.
So I think that's a very good question to ask, and it's something I've been thinking about a bit recently. So just to take the bodily case, I mean, you're absolutely right. You have control. You could take your hand off. What you don't have control over is how much damage is done to your hand while it's on the plate, and that was supposed to be the analogy. Okay. It's not that you don't have the ability to move your limbs. That obviously would be not right. So the analogy is that if you think of pain in that kind of way as something that is just about what happens to your body in certain states, you're unlikely to think it's something that you can have, apart from that kind of control about just getting it cured. You know. So that was the thought. But then that pushes you onto the other side, where I think there is a genuine question to ask, which is why would you want to say that you have control over cognitive states in this kind of way? And I think that is a really interesting question. And there are different stances, and it's interesting, there are different stances in the kind of philosophical literature, and I think in the sort of common debate, in the public domain, the view seems to be slightly different. So in the philosophical domain, I think, you know, there have been philosophers who think that you absolutely do have control over many aspects of your cognitive lives. You know, so there are some aspects you don't have any control over. You know, you might think if you open your eyes and your eyes are working, you can't control the kind of sensory input that you get. You know, you might think there are Freudian notions of the unconscious, you don't have control over those states. So there are definitely, you know, you might think that there are unconscious processings that happen that you don't have direct control over. So it's much more fine-grained. You can't just say because it's cognitive we have control over it. That's absolutely right. But there are philosophers who have thought that we have control over a substantive aspect of of our cognitive lives, that we can choose what we think about and we can choose how we reason and the results of that reasoning to an extent. So, and then there are other people, like my ex-colleague Galen Strawson, who think that is nonsense. Who think that you don't have that kind of control. The only kind of control you have is what you choose to pay attention to. So you might pay attention to this line of thinking rather than that line of thinking, but that's it. That is the extent of your control. And if you've met Galen anxiety, when I read that, I thought, oh, that explains so much about life with Galen. Trying to get Galen to do any admin was absolutely impossible, and I realised
because he hasn't got any control over it.
About whether he does it or not. But so there are philosophers who will tell you that you don't have that kind of control, and I think this is a really interesting area to think about more with relation to chronic pain. But it's not something that you find, or you kind of find the flip side, I think, in quite a lot of common discourse about pain. So particularly if you look at a lot of sort of self-help materials on pain, there is a lot of talk about along the lines of, well, you can't control what the world throws at you, but you can control how you respond to it. And that sort of empowerment seems to go alongside with this idea. And I think there is an interesting tension there that definitely deserves more exploration. So I didn't want to present the control stuff as a done deal, but I think it's definitely something that's interesting to explore.
Yeah. So I think we've got time for a couple more questions. Nathan, I saw you first, and then...
Really enjoyed your talk. I thought it was incredibly illuminating. And I'm wondering if you could speak more about sort of this pragmatic approach to understanding our intuitive concepts involving pain. So I know that there are similar approaches coming out of, for example, Carnap's work on explication, which has to deal with sort of refining what our intuitive concepts are to be somewhat better for the task at hand. And I'm wondering if your approach is entirely descriptive or can become prescriptive or normative.
So that's an interesting question. So for those of you who don't know, there's this philosopher, Capellan, and he has this big project on what he calls conceptual engineering. And the idea that what we need to do is get in and kind of fiddle with our concepts to make them better, to make them fit the world better, or to fit what we want to do with the concepts better. There are clearly parallels between that kind of approach in general and this kind of approach. I'm not a massive fan. I don't know. I don't know that I've got anything that informative to say on this point. I think it's a really good question. I think that what we've taken ourselves to be doing is more descriptive than what I think Herman is doing. Because we really do think that this is the way ordinary people think and talk about pain. We just think that it is complicated in these kinds of ways and complex and requiring further kind of articulation. As I said earlier, we're not absolutely sure that that's part of the concept. We might just be wrong about that. It might turn out to be part of the pragmatics rather than part of the essential nature of the concept of pain itself. So if that were the case, then it would bifurcate from Herman's kind of approach. And secondly, although we do think there's this sort of slightly prescriptive element in that people can come to think about pains in ways that make them more able to benefit from the kinds of treatment that will genuinely benefit them in chronic pain, and to believe in the idea that the treatment is going to help them. So another thing that really influences your how much you're going to benefit from a treatment for chronic pain is whether you think that's going to be successful or not. I mean, this is another kind of aspect of the placebo treatment. And one of the real difficulties with chronic pain patients is they've had so many treatments that have been unsuccessful, they come kind of primed for failure in a way that makes treating them really difficult. So we do think there's a slightly prescriptive kind of element in that people come to think about their pains better, but I don't think it's a general question about absolutely changing the notion of pain that we work with.
I think we've got time for one more question. Did you have a question?
Oh no, we were just talking.
You were just talking.
Break, yeah.
Well, you had a question, didn't you?
Me, it was more of a kind of thought than a question, really. And I know you didn't want to talk too much about the idea of control over pain. But is there the potential that actually instead of being empowering all this self-help stuff, it's actually disempowering in that it kind of leads us to apportion blame, and that if you can change your mental state, then it's your fault. And does that contribute to stigmatization of mental illness?
So actually this is exactly what I've just been. I did a presentation on this, and even more work in progress, even this one, on precisely these questions about chronic pain, control and responsibility. That was the title of the paper. And there is this real worry. Part of the reason that chronic pain patients don't want to be told that their pain might be psychosomatic is because quite reasonably they think that shows that they're in some way to blame for their experience, or they're going to be held responsible for it. And what we need to do is to find a way to show people that it could be a psychosomatic condition, but that doesn't mean that they want to be in pain, it doesn't mean they're responsible for being in pain, and it certainly doesn't mean they're to blame for being in pain. So, yeah.
I'm afraid so. You're going to have to stop because then another class about to come in. Sorry, that was a really good question. Thank you very much indeed.